More this time I couldn't make it. Really sorry. So I thought when Prayaag asked me to come online, I immediately accepted it. So maybe my quality of audio video may be slightly problematic. Please bear with me. So okay, fine. Okay, fine. So we are going to deal with approach to cyanotic congenital heart disease in adults, which is going to be invariably one of your short cases or even at times a long case also. So I'm going to make it as simple as possible so that everybody understands. So cyanosis in adults in terms of the frequency of occurrence as well as the expected survival can be classified into these three categories, where common defects with expected survival are likely to be top in Eisenmenger syndrome. The uncommon defects with expected survival being Epstein anomaly and PS with ASD, that is initially called as triology of Fallot. The uncommon defects within which adult survival is exceptional include all the other various conditions like TAPVC, DORV, TGA physiologies, univentricular hearts, truncus arteriosus, and tricuspid atresia, and so on and so forth. So, how do you approach an adult with cyanotic congenital heart disease? The moment it starts from the history, as typically as you encounter in a case. So, how are you going to approach it from history? So, the $1,000,000 question is going to be whether it is going to be a TOF physiology or is it going to be Eisenmenger syndrome? That is the primary question that we are going to answer. So, how are you going to, what are the pointers in history that is going to tell you about whether it is tetralogy or whether it is Eisenmenger syndrome? The important ones are the quantum of cyanosis, the nature of cyanosis, and the progression of cyanosis, the occurrence of spells, and the history of spotting. These are the three important features by which we are going to differentiate tetralogy from Eisenmenger syndrome. So, one of the important things is we all know this, the timing of heart failure in congenital heart lesions. We know that, okay, in cyanotic congenital heart disease, so the heart failure starts in these situations, and acyanotic also, the heart failure doesn't occur till 6 weeks of life because the PVRI is very high and there is no excess left to right shunt. This kind of a thing is very well known. Same thing can be applied about the onset of cyanosis also. The onset of cyanosis can be at birth to 1 week of age, where I think the three important conditions that comes to picture are TGA physiology, pulmonary atresia, and TAPVCs. And HLHS comes till 2 months. HLHS also commonly found, right? And Epstein, we all know that is a very important condition that presents in the neonatal age group and later on in bimodal presentation beyond first decade of life. So Epstein is something that we should know. Critical tetralogy behaves like a pulmonary atresia and can present with at birth or first week of life. Then it actually transitions from TGA, pulmonary atresia, TOF, TAPVC, HLHS to TOF becomes the most common lesion beyond the few months to few years of life. Then you have TAPVC, balanced physiologies, and truncus comes to that. And later on, it becomes, by the first decade, it is TOF, TOF, TOF. Then you have Eisenmenger syndrome, Epstein, and balanced physiologies come into the picture. And beyond 3 decades, it's going to be TOF, ASD Eisenmenger, CCTG, VSD, PS, and some form of single ventricle PS. So the onset of cyanosis helps you in differentiation. What are the possibilities? Other specific histories features are whether history of heart failure is there or not, whether in any history of increased failure to thrive is there or not. Because heart failure is uncommon in tetralogy-like conditions. It is commonly found in increased QP physiologies and when there is a ventricular dysfunction or when there is AV regurgitation is there. So these are situations cyanosis as heart failure in general. Then you have failure to thrive is increased QP. There is some syndromes and top with absent pulmonary valve. So these are situations where you can have failure to thrive. Then hemoptysis can be found in both TOF and Eisenmenger syndrome. And tachycardia, like palpitation, like history, can be found in Epstein, AV canal defect, and corrected transposition. Then syncope can be structural because of structural, like the hemodynamic cause of syncope, like in PS or Eisenmenger syndrome, or because of AV blocks in AV canal defect, CCTG, and heterotaxy syndrome. So both these conditions, tachycardia, the condition that produce pathway, as well as AV block, have something common in the AV junctional problems, like, for example, AV canal defect, corrected transposition, or you have the heterotaxy syndromes where there is a problem. So what is the typical prototypic tetralogy physiology in terms of examination wise? So before that, I think I told you like two important things that differentiate will be presence of spells as well as the presence of splatting. Spells, we know that it is commonly found from 2 months to 2 years of age, with the peak incidence around 6 months of age. And generally, it is spell-like features are absent in Eisenmenger physiology. Rarely, pH crisis can happen. Mostly, pH crisis happens in when the defect is closed. It's a post-operative phenomenon mostly. Coming to squatting history is generally considered specific for tetralogy physiology, even though Indian studies report around 5 to 10% of patients with Eisenmenger syndrome also may report to squatting. So you'll be asked what are the mechanisms of spell, or you'll be asked what is the mechanism of squatting, how squatting relieves sinus and all. So from history, we want to differentiate from tetralogy and Eisenmenger based on the onset of cyanosis, the quantum of cyanosis, and the progression of cyanosis. We'll go into the depth of all of them later. Then cyanotic spells as well as squatting. So we go to the examination finding. What do you find in tetralogy like physiology, PS with VSD, typical large unrestricted VSD with PS is a tetralogy physiology. What you find is you generally find nothing, literally. The JUP is usually normal. There is no cardiomegaly, no heart failure, no parasternal heave, no thrill. S2 is also single, and there is a small little murmur, which is also inversely proportional to cyanosis. The moment cyanosis is very severe, you find a short murmur. Same thing holds true in Eisenmenger also. Most of the Eisenmengers don't have a loud murmur. Loud murmur means PS, and that is also intact septum. So diastolic period is also clear. The simplest thing to remember is tetralogy physiology has literally no major clinical finding except for a short little murmur. So what are the different tetralogy like physiology you can encounter? So these are the various tetralogy like physiology that you can encounter. Is VSD with PS, you can have DRV with PS, then you have tricuspid atresia, you have TGA, you have corrected TGA, then you have AV canal defect, single ventricle with PS, and heterotaxy syndrome. So can you clinically distinguish between these things? The moment you have made up your mind, okay, this is tetralogy like physiology, based on the finding, what are the situations that can be clinically diagnosed with some accuracy, some sensitivity, specificity is what we are going to discuss. Can you think of something? What are the things that can be diagnosed clinically? Like your thought of tetralogy physiology, what are the things that can be clinically diagnosed? The most important thing is an LV apical impulse. So remember that it's all tetralogy like condition, all cyanotic angel heart disease, predominantly pulmonary arterial circulation problems and right-sided diseases. In such a situation, if there's left ventricular heaving apical impulse, a significant LV apical impulse is there, then there are very few conditions that can produce that. So that is very specific thing. Suppose the moment you say it's an LV dominant condition, then your diagnosis, differential diagnosis moves to very limited line. So in tetralogy physiology, that line includes classical tricuspid atresia VSD-PS. Then you have single ventricle with PS. Then very rarely you can have DVRV with restrictive VSD with PS. What is this DVRV with restrictive VSD? Remember, this is an extremely uncommon condition. In my life, at around 20 years of practice at AIIMS, where I would have seen around 5 to 10 cases of DVRV with restrictive VSD with PS. So it's an extremely uncommon condition. But what is the condition? So there is DVRV. That means both the great arteries are arising from RV, and the VSD is the only outlet for that LV. Understand? Only outlet for that LV is that VSD. So now the VSD is getting restricted. That means it's almost behaving like an LVOT obstruction. It behaves like an atrial aortic stenosis like for that patient. There's a significant LVOT obstruction. It produces a typical heaving apical impulse. So these are the three conditions in tetralogy physiology. In non-tetralogy physiology, LV apical impulse with cyanosis can be found in pulmonary atresia of the intact septum and Epstein anomaly. So all these conditions have something in common, except for a LV dominant single ventricle and DRV restrictive VSD. All the other conditions, the RV is diminutive, so the LV impulse is the predominant impulse. So the tricuspid atresia, single ventricle, DRV restrictive VSD are the top physiology with LV apex. Epstein anomaly and PA-IVS are the ones non-tetralogy like physiologies with LV apex. So cyanosis, LV apex, these are the 5 conditions that can produce. Other important thing is the L post aorta. So if you can see my hand, so this is my L post aorta. L post aorta is what is L post aorta? Aorta is left and anterior. So in the pulmonary area, you will have a aorta lying there in a CCTJ, classical CCTJ like situation. You find a palpation and you find a loud sound that is palpable, aortic sound that is palpable in a tetralogy like situation. You should think of CCTJ. That is L post aorta. The other important thing is cyanosis, which is out of proportion to the murmur. As I told you, tetralogy has cyanosis, which is the murmur is inversely proportional to cyanosis. What is happening is the murmur is generally out of proportion to cyanosis. What is the reason? Like I teach, like, okay, if there is a hemodynamic reason for cyanosis, what are the hemodynamic reason for cyanosis? It has to be a step down physiology. That means the oxygenation is happening complete in pulmonary vein. Oxygenation is complete in LA and LV into aorta. There is some step down happening. There is some mixing happening, right to left channel. Classical being tetralogy or Eisenmenger. There is a PS or PAH physiology producing the mixing happening. So that's a right to left shunt happening because of step down physiology. Other physiology could be an admixture physiology, or it can be a transposition physiology. So what are we dealing with? Here we are saying is the PS is significant, loud murmur is there. That means the PS is significantly there. But at the same time, you are having severe cyanosis. That means some other reason, for example, admixture physiology or a transposition physiology or streaming is actually playing a role in causing the cyanosis. Understand? So there is a step down happening significantly. Then the murmur has to be inversely proportional. But here the murmur is not inversely proportional because the cyanosis is caused by an admixture physiology or a transposition like streaming that is happening. That happens in DORV or complex interplay and TGA physiologies. So this is the typical L post aorta I was talking about. So the left and anterior aorta that you can palpate. There are various other small little things that can be added up, like murmur of heavy valve regurgitation can be found in AVSD and CCTGA. Early diastolic murmur, EDM of TR, can be there in absent pulmonary valve, but commonly you can have it because of AR also. Top with AR also can be found in our country. Complete heart block is generally CCTGA. The other important clue towards CCTGA is the occurrence of situs and the position of the heart. There is a discrepancy. So situs solitus and dextrocardia, situs inversus and levocardia, the chance of CCTGA increases tremendously. There are some minor points in terms of cyanosis. Generally, the cyanosis, the quantum of cyanosis is much more in TGA and TORV, VSDPS comparatively, and it's maybe lesser in single ventricle and CCTJ, but these are all relative points. So in nutshell, LV apex is the most important thing to differentiate between tetralogy, physiology, and CCTJ can be convincingly diagnosed if the condition is there is a discrepancy between situs and the cardiac position, or there is a L post aorta that you can palpate or a sound that can be auscultated there, or rarely can be because of complete heart block or presence of AV regurgitation. These are the things that you have to see. So other important thing that you have to think of is what is the difference between intact ventricular septum and VSD with PS. PS with intact ventricular septum, or otherwise known as the triology of Fallot, earlier called as triology of Fallot. PS with intact ventricular septum with a right to left shunt happening because of an ASD or a PFO. Everything is opposite. What I told you. Tetralogy is nothing. JVP is normal. Here JVP has a prominent A wave. If there is heart failure, there can be CV waves, and there should be cardiomegaly. There has to be a parasternal heave. The S2 depends on the pathology. There can be RVS3 or S4, and the pulmonary ejection murmur is very prominent and is proportional to severity of the condition, and it's a late peaking murmur, and there can be a TR murmur that can be found. So, in nutshell, so the moment you identified this is tetralogy physiology, you knew the tetralogy physiology, what are the classical feature, the important differential diagnosis being intact septum with PS, and among the tetralogy physiology, how do you clinically differentiate? I have told you. So am I clear? So tetralogy physiology should know the classical features, and among the tetralogy physiology, which are the ones that you have to find out, how do you make out all this, and then you go to the typical triology physiology or the AS with PS, intact ventricular septum, how do you differentiate? So same way, how do you approach an Eisenmenger syndrome? So if the primary diagnosis is Eisenmenger syndrome, so this is the classical Fallwood series that you should know how many had defect and how many ended up having Eisenmenger syndrome, all those things. But it has become kind of a history, but still examiners are fond of asking that. So you may have to think about it. But this is the real story, like one of our patients who had VSD with increased flow with cardiomegaly. Even at that 2 years of age, we did cardiac catheterization and found to be operable. But later on was lost to follow-up and comes back with this X-ray. These two X-ray teaches you a lot. So how the Eisenmenger syndrome develops, how the clinical pictures emerge. So from an increased QP with a LLV volume overload, things have settled, and that actually has become Eisenmenger syndrome. There is no cardiomegaly. The signs of PAH predominate. So that is what it is. So Eisenmenger syndrome is generally secondary to large VSD, PDA, and later on ASD. And rarely it can be because of AP window and cyanotic angel heart disease with increased pulmonary blood flow. So what age a typical VSD Eisenmengerize? This is a common question that I often ask. Generally, the answer to this is 2 years. Most of the VSDs, if they become inoperable by around 2 years of age. Remember that the operability and inoperability is a kind of a process. We want to say, okay, you are passed, you are failed. So that kind of a thing doesn't happen in life. It's always a process. That process is an extensive process that goes on from, say, a VSD becomes borderline operable to borderline inoperable to absolutely inoperable. So that process starts around 1 year of age, and most of the patients with large VSD may be inoperable by 2 years of age, even though the clinical symptoms start happening at around 20 years of age. That is where the confusion happens. Most of them, there is a confusion. When this question is asked, many of them answer like it's 20 years. But symptoms of dyspnea happen in VSD. Exercise limitation starts to maximize at 20 years of age, but the process of inoperability starts around 2 years of age. The key concepts is established by around 1 to 2 years of age, whereas ASD may take 1 or 2 decades. The closure is detrimental, and the best thing is when you are in doubt, you should not operate. The median survival is roughly around 30 to 40 years. Now, maybe it is going up to 40 years now in uncomplicated lesion. But the moment you operate them, their longevity goes down and they become a kind of a IPH. Their longevity is limited to few years. So this is the important survival graph. Even the survival is limited compared to the normal natural history. But the most important thing in Eisenmenger is that most of them die due to ill-advised medical procedures, including pregnancy. So survival is better than patient with IPH, and unwarranted procedure is not needed. So coming to the clinical features and clinical recognition, so I always say that there are 3 different subtypes of Eisenmenger that happens. So the most common thing that we always want to listen to or always want is roughly around found in 50% of patients. That is, there is a history of failure to thrive in infancy. There is recurrent heart failure and recurrent admissions, and there is a settled phase. The heart failure settles down, the recurrent heart pneumonia settled down, and then they became later with symptomatic adolescent phase. That is classically found in around 50%, 60% of patients. The insidious presentation is also very common in our situation, where they never have been shown to have heart disease and suddenly presented to around 16, 20 years of age with the exceptional limitation and onset of cyanosis. Why there is absence of the heart failure and recurrent respiratory infection? Some of the explanation is there is non-regression of PVR. So the PVR has to reduce, but in some VSDs it doesn't reduce. So they have never gone through the space of increased QP and the cycle of recurrent respiratory infection. Some of these conditions, like the single ventricle physiologies or the complex physiologies, may present with cyanosis since birth. The TGA VSD PH, for example, they can present with cyanosis since birth, but they become Eisenmenger very early, and they generally die by around 10 to 20 years of age. So adulthood survival is uncommon in these conditions. So the cyanosis is ASD is cyanotic at an earlier age, the same amount of pH, but generally ASD becomes cyanos later on. The JVP is predominant AV we've seen in around 20 to 90% of patients, adult patients. V wave is rarely found. The heart is not enlarged in VSD and PD and common garden Eisenmenger except for ASD. We'll come to that later. And the parasternal heave lift is also variable. P2 is loud and palpable in 2/3 of patients. Ejection click in most of the patients. EDM of PR is found in 1 up to 2/3 of patients. 10% may have a thrill. S2 is single in 50% of VSD, 5 to 20% of PD and 20% of ASD. Wide split is rare in VSD but common in ASD mainly. So coming to the clinical feature, cyanosis is generally mild. There is no cardiomegaly, there is no heart failure, minimal left parasternal shift, absence of significant shunt murmurs, and signs of pH prominent, constant ejection clicks of pH, and pulmonary regurgitant murmur may be audible. So what are the signs of pH that we are looking at? Palpable P2, palpable RVS3S4, palpable pulmonary artery pulsation, the characteristic percussion notes. The peripheral buoys may be found in continuous murmur in axilla, and pleural efficiency may be found. Loud P2, how do you say it's loud P2? Commonly asked question. You always compare it with A2, whether the P2 is heard at the apex or not, whether it is palpable or not. RVS3, S4, constant ejection click, murmur of TR, ejection systolic murmur, which is generally faint and early peaking murmur, and a murmur of PR. These are all the signs of pH that we are looking for. So if there is a TR murmur, you have to differentiate whether it is a high pressure TR or a low pressure TR. That generally is done by the murmur is a pansystolic murmur in high pressure TR with a high pitch murmur with a PSM shape, with P2 being loud and CV waves are there. Whereas low pressure TR will have an early systolic murmur with variable duration, low pitch murmur, a decrescendo characteristic with the P2 normal. Like. So same way, high pressure versus low pressure PR, high pitch versus low pitch, longer duration. Like high pressure PR murmur is like your AR murmur. So whereas a low pressure PR murmur is a low pitch, brief decrescendo murmur with other features absent. Prominent PR is found in PDA with PH. So X-ray wise, another important differentiation you are supposed to make is between hyperkinetic PH and the Eisenmenger syndrome. So I want to differentiate you, tell you the differences between ASD, VSD, and PDA differentiation. But X-ray helps you in understanding. So ASD Eisenmenger classically will have right atrial and right ventricular enlargement, whereas VSD and PDA don't have any cardiomegaly. Whereas the PA segment is prominent. These are the signs that you find. So these are the underlying lesion. What are the commonly found underlying lesion? Most often than not, it is VSD. Rarely it can be PDA and then ASD. So which of the clinical sign is unlikely in a VSD Eisenmenger syndrome? Single S2, palpable second sound, cardiomegaly, and absent parasternal heave. Not likely in a VSD Eisenmenger. So you're right, that is cardiomegaly. This is a very important table. The usual age of Eisenmenger is generally 2 years in VSD and maybe 1 to 2 years in PDA and 20 to 40 years in ASD. Differential cyanosis is found in 50% of PDAs. Cardiomegaly is a feature of ASD, not a feature of VSD and PDA. T2 is generally single in VSD, narrow or normal in PDA. It's variable generally. Or ASD is generally wide and fixed. Parasternal heave is found only in ASD. TR murmur is classical of ASD and PR murmur is classical for VSD, PD. So PDA PH is classical for PR. So I think I come to the end. So Epstein anomaly, I won't be discussing in detail. So Epstein anomaly is something that I think we can have it for some other class. So it has typical ECG and many X-rays, and a lot of arrhythmias are now associated. This is a very classical X-ray that is found. So maybe I will be sharing these slides with Prayaag anyway. So you can have a look at this slide. For want of time, I won't be going into the detail of all this. So these are some of the issues that can happen. The cardiac issues that can happen: myocardial dysfunction, AV valve regurgitation, dilated aorta is emerging as a very important thing. Aortopulmonary collaterals, arrhythmias, and infect endocarditis. These are the non-cardiac issues that can happen. So a lot of these issues are there. But these two slides are very important. What are the pregnancy outcomes in all this? So remember, like for the mother, the worst conditions are Eisenmenger and PH type situation. For the fetus, it is always the severely blue condition with fixed cardiac output are the worst conditions, like the Fontan and the other ones. Like remember that. Like so this is another important slide. What is the risk of CST in the fetus if the father is affected, if the sibling is affected, and the mother is affected? This is something that you should know for not only for your exams but for overall prognostication of a family. So the fetal audiography should be offered at around 18 to 20 weeks or so. So I won't be dealing with the other increased flow or pulmonary venous congestion lesions and the normal pressures with cyanosis. Like so, I think cyanotic annular disease is very simple. You don't have to do something like this to make out what is the diagnosis. Keep it as simple as possible. First question is whether it is tetralogy or Eisenmenger. If it is tetralogy, is it tetralogy or tetralogy-like physiology? Whether it is like simple things like ASD with PS, intact septum or with tetralogy typical, or it is pulmonary atresia-like situation which can be no murmur, a lot of auscultation on the back with collateral murmurs, no murmur at the RUOT, pulmonary atresia. That's typical of pulmonary atresia. You can have top with absent pulmonary valve, which is a top with the idiom, like top-like picture with an idiom. So these are the ones that can be differentiated. Among the top physiology, I have told you how do you differentiate. Same way, what are the typical Eisenmenger syndrome and what are the ways to differentiate between Eisenmenger syndrome, I have told you. So hope you enjoyed this lecture. It's very simple provided you have an approach. And these are the essential textbook that I would recommend for you to read. I think these are very good sources for you to read. So thank you for patient listening.
We will stay for maybe a minute more. Are there any questions to be asked to sir? I'll give this open. Any questions anybody wants to ask, sir? Especially join us from Rishikesh. We practice sitting outside there because you won't get internet connection inside. Sir, thank you so much for taking out time for us, sir. I really wish you were here. And next year, sir, you have to join us physically again.
Yeah, absolutely. I will first lock speed. Unfortunately, this program also I made and I can't avoid that. The PG track, I made the whole program. So I'm doing the PG track here also.
So thank you so much, sir. Thank you for joining us.
Thank you. I will be sharing the slide. I'm happy to share the slides.
Certainly, sir. Certainly. I'll share it with all the day.
Thank you. Thank you. Thanks a lot. Miss you all.
Thank you so much, sir. Thank you, sir.
Thank you.
We will break for tea now, short break. Delegates on the left, take the tea on the right, and we come back for Dr. Patnaik's lecture on recent trials.